there's so many things you can kind of touch on with estrogen positive breast cancer in these treatments. So let me share my screen. There we go. Perfect. So let me go. There we go. So just to kind of start out with some breast cancer facts. So there were 268,000 new cases of invasive breast cancer that were diagnosed in 2019. There were an estimated 48,000, a little over, cases of DCIS or ductal carcinoma in situ. And so just to kind of go into that a little bit, if you are my patient, then I've probably done like a chicken scratch drawing of this for you, but this is a nice way to kind of look at everything. So if we look at the breast here, you know, you have some of the fat lobules in there. Here we have the lobules where you actually make the milk production. And then we have, you know, ducts, as you can kind of see magnified here. And so just when it comes to kind of the location, so the two most common types of breast cancer are ductal and lobular. So just from an anatomic standpoint, that's where we kind of see these. Now, interestingly, on a mammogram, it's actually much easier, typically easier to see a ductal cancer. The lobular cancers here, they tend to be a little bit more scattered and not as mass forming. So at the time of surgery, sometimes those are the ones that we're a little bit surprised, where the size could have been a little bit bigger than it was kind of originally noted on mammogram. No, certainly that can happen with ductal as well, but it's just less common. So we talked about both DCIS and then invasive breast cancer, and these are really very separate entities. The DCIS we think of as stage 0 breast cancer, so we do think of it as breast cancer because these are abnormal cells kind of within the duct. So if this is the duct and you kind of have cells kind of lining it, then all of a sudden you get these kind of abnormal cancer cells in here. But the key with this is in situ means superficial. So the cells are really kept superficially kind of within the duct. And if we move to the next depiction here, one of the hallmarks, I think, of cancer is kind of its ability to invade, kind of structures that are close by to it. And you can see here, this is when the cells seem to be kind of invading or kind of pushing through the wall. Now, then what they're going to try to do is find their way to the lymph nodes or kind of grow further within the breast. And that's one of the keys of kind of early detection before cancer gets larger or certainly spreads more. So 81% of breast cancers are invasive, and then 75% are ductal and 15% are lobular. So it leaves about another 10%. There's quite a few different types of histologies for breast cancer. So kind of what they look like when you're looking at it under the microscope. Tubular, mucinous, cribriform, papillary. So these are all very rare, but they are luckily associated with a more favorable prognosis. So hormone receptor positive breast cancer. So there are really 4 major subtypes of breast cancer. And one of the primary ways we can kind of look at it is the different biomarkers. So by biomarker, we just mean the estrogen and the progesterone positivity, which are really kind of the 2 primary female hormones that we think of. And then there's this other marker that we look for called HER2, and it's kind of it's more of a receptor on a cell. And I'll kind of explain that a little bit more in a little bit. But you kind of get this combination. So 84% of breast cancers are hormone receptor positive. So we kind of look at this large spectrum of them, but then we have another 11% that are not only HR positive, but then HER2 positive. And then not to be left out is the triple negative at 12%, and then the HER2 positive, but then hormone receptor negative. So the way I kind of think about the cells in breast cancer is we have receptors on these cells. And so that's really what we're kind of staining for when we talk about hormone receptor. And a receptor is defined as a region of tissue or molecule in a cell membrane. So we think of this as being a cell membrane and then something kind of sticking out from it. And it responds specifically to either what we call a neurotransmitter or hormone, or Antigen, we've been hearing the word antigen maybe a lot with vaccines recently, or other substances within the body. And so in this example here, they call this a ligand, but we can think of this as maybe estrogen, and this is an estrogen receptor. And so what we kind of have is that when this kind of binds into that receptor, they're kind of attracted to each other, and then a signal gets sent to the cell to tell it to do something. And usually in this case, it would be to kind of reproduce or grow. So it's kind of fueling the growth of cancer. And then this is just another way to kind of think about it. So again, we have a kind of a normal breast cancer cell here. We have, an estrogen receptor. And then here we have, receptors on the cell. And these are really what pick up the stain when we're kind of looking at them. And this is really what we want to target when we're thinking about treatment or kind of going after breast cancer from an anti-estrogen standpoint and not just a chemotherapy standpoint. And that's one of the best things I think we've been able to do over the last 10 to 20 years is really focus on some breast cancers really don't benefit. A lot of them really don't benefit from chemotherapy. And we're able to really focus on this anti-estrogen aspect of it all. Now, when it comes to HER2, we think of HER2, I know that's not what this is about today, but also just kind of being a receptor on the cell. And so again, something else that we can stain for and something else we can kind of target for when we talk about treatments. Now, I think Dr. Miser had given the talk on that, so I will kind of defer to her on that one. So how do we use what we know to fight breast cancer? So we have 4 kind of primary medications that we use, and really we'll be talking about more early stage breast cancers here. Certainly happy to answer any questions about any additional, but the anti-estrogen medications, so we have tamoxifen, and then we have 3 aromatase inhibitors. So we have anastrozole, we have letrozole, and we have exemestane. So to kind of go into tamoxifen a little bit, so it is called a SERM. There are other medications that we use that are called SERMs, but we don't use them in the early stages. So we have Faslodex or fulvestrant, if anyone is taking that or has heard of that, is also a SERM. And there's also a lot of studies right now that are looking at medications. We think of Faslodex or fulvestrant as an injection given every 4 weeks as being a stronger medication than tamoxifen. It's the way that it works, and it's I don't know if I'd say it's better, it's just stronger, but they are looking at oral options for those as well. So what tamoxifen does is it binds to that receptor. So that's kind of one of the reasons why I talk about those receptors so much, because we have these receptors on the tumors, and it binds to these on the tumors and other target tissues, and it basically produces a complex that decreases DNA synthesis. So basically it just decreases cell division or the ability of the cell to grow. And then it inhibits the estrogen effects. So it's really kind of cutting off the fuel to that fire. So tamoxifen reduces the risk of breast cancer recurrence or invasive breast cancer. So it really has more than one role here. So it reduces the risk of breast cancer in the opposite breast by about 50%. And so, and reduces the recurrence in premenopausal women by about 30 to 50%, recurrence in postmenopausal women by about 40 to 50%, and then also reduces the risk of an initial invasive breast cancer diagnosis by about 40%. And so the difference between that top line where it says opposite breast by 50 and then initial breast, so opposite breast, so if we say the right breast is affected, by taking tamoxifen, you're also giving some prevention to that left breast or that opposite breast, because once you're diagnosed with one breast cancer, you are unfortunately a little higher risk of getting diagnosed with a secondary breast cancer. And then just that initial breast cancer diagnosis. So for example, patients who have DCIS or they have a strong family history, some of those patients will decide to go on medication like tamoxifen for prevention. And what it does is it reduces the risk of ever developing an invasive breast cancer. Now, that being said, I think it's always important whenever I'm having these discussions with my patients to point out that it does not, in that specific case, improve survival. So it's a little bit more of a gray area in terms of whether or not you really should or how strongly we end up really kind of recommending it. So again, kind of back to these similar pictures or depictions, but tamoxifen would normally bind to the receptor, and then the estrogen can no longer bind, so it's just kind of there. And if this is the tamoxifen, it's just kind of holding place in that receptor. So, really kind of cutting off what estrogen does to help fuel it. And then again, similar way to kind of think about it. I think most of us are pretty visual learners, so I always like to give kind of more than one example. And so we have, progesterone and estrogen, and then tamoxifen just kind of fits in there, and we're not able to utilize any of it. Next, we have aromatase inhibitors. So aromatase inhibitors are the class of medication that we use for patients who are postmenopausal. So for tamoxifen, we can actually use it in women who are pre and postmenopausal, although we know that aromatase inhibitors are proven to be a little bit better. So, we prefer to use aromatase inhibitors in patients who are postmenopausal, but sometimes there are contraindications to doing that, or someone doesn't tolerate it. So the way an aromatase inhibitor works is we have essentially testosterone here, and it gets converted into estradiol or estrone, so kind of the female hormones. And it does it with an enzyme helping it called aromatase. So being the clever scientists that we are, we use aromatase inhibitors to go in and kind of block out that aromatase and really block the body's ability to make estrogen. So it is this is where we really use the aromatase inhibitors, and I think they're kind of depict here that this would be more where we would use tamoxifen kind of in that cycle. So again, the 3 different aromatase inhibitors, head-to-head studies in advanced breast cancer actually show that they have similar efficacy. So I remember being at a conference a couple of years ago, and certainly I think there's one that thought they were going to kind of win out a little bit over the other because it has this very ever so slightly different mechanism with which it works. And all the lines just kind of were on top of each other. So they all are really just as effective as the next. They also have very similar side effect profiles that are nearly identical. So a lot of times it just tends to be kind of your oncologist preference, who they trained with, is really, sometimes it can be regional in terms of kind of what their preference is between the 3. So aromatase inhibitors reduce the risk of developing invasive breast cancer by about half to 2/3. So that was kind of, again, that group that's taking it more for the prevention. And then there's a 35% reduced risk of recurrence versus tamoxifen. So it is found to be slightly, reasonably superior. Again, I think 35% is all relative depending on what your true risk is. So the higher your risk, the bigger the benefit you'll get from taking an aromatase inhibitor versus staying with tamoxifen. And so the benefits also remain, although they are lower when you switch someone to an aromatase inhibitor after taking a short course of tamoxifen. So I think a good example of that is, we have many women who at a certain age, if they receive chemotherapy, oftentimes we would be surprised or not necessarily expect for them to continue ovulating and menstruating. So sometimes instead of suppressing their ovaries and putting them on an aromatase inhibitor, we would choose to kind of put them on tamoxifen, monitor their hormone levels for a little while, and then potentially switch them to an AI. So there's also studies that just look at even if someone has not been on, didn't receive chemotherapy, and you're just a little bit more unclear of their kind of true menopausal status. This happens for a lot of women who've had, ablations or hysterectomies, but their ovaries have been kept intact. And so we really don't have a good way to say, well, when was your last menstrual period? So we really like for the menopause portion of everything to be defined very well, because if we give you an aromatase inhibitor and you're premenopausal, we're really not helping. Really not helping at all. It's really not giving you any benefit there because your ovaries are still making estrogen. So the fun part of my visit is always talking about the side effects with the patients, because it really is tough. And really what we ask all of our patients to do, it's just extraordinary. I'm really not just saying this, that what women can handle. And it's also incredible to me how the varying degrees of side effects are with everybody. And it has truly nothing to do with your level of toughness. It's just our bodies are all so very different. And I wish that there was a test that I could order that would say, you know, you're going to be fine. You're not going to have an issue. I try to be optimistic and say, well, if you didn't have a lot of problems with menopause, maybe you'll do better. But I have plenty of patients that have really struggled with menopause and they go on these medications and they're fine. They have no issues. So I always say to patients, there's really this large spectrum. So you have the patients that you put them on the medication, they don't notice any difference. They're kind of like the women who have no symptoms in menopause. You don't really want to tell everybody because you'll make your friends mad. And then you have the other spectrum where patients will sometimes take it for, 1 or 2 days, and then they can't handle it and they have to stop because the side effects are just kind of too severe there. So a lot of the side effects can be very similar, menopausal type symptoms. So we have hot flashes and night sweats, vaginal dryness, although I will say it is noted in both. I do tend to find that it is more prevalent in someone who's taking an aromatase inhibitor. With tamoxifen, oftentimes you'll get an irregular or a loss of your menstrual period. That certainly does not always happen, but it's not uncommon. Fatigue. And then very, very rarely, we'll see sometimes blood clots, acceleration of cataract. So it certainly doesn't cause the cataract, but it may cause you to need something sooner than you would have otherwise. And then endometrial or uterine cancer. In terms of other side effects for the aromatase inhibitors, we had mentioned fatigue on the tamoxifen side as well. I tend to find hair thinning and dry skin tend to be more on the aromatase inhibitor side, although I think the spectrum of side effects that you can get is really, really quite vast. The big one for a lot of patients is kind of joint or muscle pain. In one area, I saw that they said it was only about 15%. And that was kind of in one of our major medication resources. In looking elsewhere, it says it can be as high as 36%. And that I think is much more on target. And when we talk about joint and muscle pain, it tends to not just be kind of one isolated joint, my right knee, my left hip, things like that. It tends to be a little bit more diffuse. And really the easiest way to test it is oftentimes to have patients, I tell them to take about 2 weeks off of it if the symptoms are so severe and this is what we really want to figure out if this is the culprit. But oftentimes if it ends up being this medication, within 2 to 3 days, patients really do feel better. And then we kind of know something we want to try to work through. Do we want to try to switch medications, things like that. And then the other tough one on the aromatase inhibitor side is osteoporosis. So it was quoted at 11%, but then as high as 20% in patients with pre-existing osteopenia after 3 to 6 years of an aromatase inhibitor. Now I'll kind of go into a little bit of additional information at the very end that I added on last night about bisphosphonates and bone hardeners, which is something that we do recommend in patients who are taking aromatase inhibitors. In terms of tamoxifen, some of the benefits that we can get. So it does actually prevent the bone loss after menopause, and it can lower the cholesterol levels. So kind of the opposite effects that we're seeing a little bit more with the aromatase inhibitors. Now, this is always a hot topic in clinic, extended endocrine treatment, so kind of 5 versus 10 years. And, I think the data is incredibly strong for 5. There's really no question about it. I think you're going to be hard pressed to find an oncologist who isn't more enthusiastic about 5 years. I think 10 is where things become a little bit more subjective. We love it when we can give a more objective answer, but the reality is I think the data is continuing to evolve and everyone has a little bit of a different take on it. Most of the literature that I see kind of recommends that if patients have, high lymph node burden or a larger tumor size, by larger, they mean usually greater than or equal to 5 centimeters. And then, obviously the ER positivity. So if you had a pretty low ER positive breast cancer, it's really hard to say that extending treatment is really going to be as beneficial, whereas somebody who had 80, 90, 100% positivity, so very strongly estrogen positive. The other kind of interesting thing with the ER positivity comment is that it tends to be you know, the patients who are ER positive are ones who can recur later, unfortunately, although certainly at a much lower percentage than the patients who are ER negative. And, you know, usually if you're going to recur with a lower ER positivity, it tends to happen sooner. So none of these are completely set in stone, but it just tends to be kind of general rules of thumb. So data does show that there's improved disease-free survival and possible overall survival with extended anti-estrogen treatment. Now, I think to me, when I read that as an oncologist, the word that you want to be a little suspicious about is possible. And so, you know, I think for some patients, we believe that there's a smaller benefit, but we're talking about, you know, lower single digits. The disease-free survival, which is basically, you know, the recurrence risk is lower, is a little bit more. And that's partly because patients who have ER positive breast cancer just tend to do better overall and tend to do well, even if they were to recur. We can, you know, with more confidence say that it reduces the risk of a second breast cancer, usually kind of in the opposite breast or contralateral breast, we would say. So there's a small benefit for some. It may be worth it, but I think it's definitely worth a discussion. I personally like to say, you know, let's see where you are at 5 years. Let's see how you're tolerating it. Let's see where the data is. And, you know, and it's really one of the more individualized decisions that, you know, that we'll make. And I think a lot of this decision is very patient driven. Whereas I feel like, you know, we'll push more for the 5 years, but sometimes for the 10 years, I don't think we have as much strength in some of our data. So a lot of it is going to be where's the patient's comfortability kind of with all of it. Two other kind of really interesting trials or information that we have for kind of blocking estrogen is called the SOFT and the TEXT trials. So we call it OS plus AI, so ovarian suppression. And so, you know, essentially some of the trials looked at ovarian suppression. So we essentially give patients a shot every month and we suppress their ovaries so they can no longer make estrogen. And it looked at doing that with tamoxifen or an aromatase inhibitor versus just doing tamoxifen alone. So there were kind of three different groups there. And when you looked at tamoxifen plus versus tamoxifen plus ovarian suppression, there's about a 6% survival benefit. So even with just, you know, the tamoxifen alone, adding the ovarian suppression and not using the aromatase inhibitor was still more beneficial. And then in tamoxifen versus an aromatase inhibitor plus ovarian suppression, there's about a 9% benefit. So again, I think a lot of this correlates to what is your overall risk, because for some patients, their risk is barely even, you know, either of those numbers. And so certainly doing this treatment isn't going to give them that kind of full benefit. So I think it's, you know, having a lot of discretion with, you know, who's higher risk and who's really going to benefit more from it. Because I think one thing that I would like to think we've done nicely in just medical oncology, I can certainly speak for it more, breast cancer, that being kind of my field, is that sometimes less is more. For anyone who's had an oncotype, that is exactly, you know, the beauty of the oncotype is that, and if nobody has, I'm certainly happy to talk about it if patients aren't familiar with it, but the beauty of the oncotype is that it has allowed us to avoid chemotherapy in so many patients. And so we don't want to just do something to make ourselves feel better, patients included, because our patients are very, very motivated and they'll do what they need to do. But, you know, if it's not going to help them and potentially give them more toxicity, I think we really have to use, you know, use our discretion. In general, we think of the preferences being for ovarian suppression plus an aromatase inhibitor. And a lot of that is kind of based if you just look at the 6 versus the 9% there. And then the last slide that I have is on bisphosphonates or bone hardeners. So the primary bisphosphonate that I use is reclassed. I was using more Prolia, but I think the pricing of Prolia has gone up considerably. It's just getting more challenging. And they really are equally thought to be beneficial. There's some benefits to a shot versus an infusion, but you know, reclass is an infusion. It takes about 5 to 10 minutes to infuse. Certainly there's longer wait time with getting drug mixed and waiting in the chair and all of that, but Nonetheless, it's a pretty quick treatment. And what this primarily does is helps lower the risk, or my probably favorite benefit is reduces the risk of developing breast cancer in postmenopausal women. So we found that the risk, especially kind of in the bones, is lower. So we're not completely sure. There's a lot of theories and hypotheses about how this medication has, or this class of medication, excuse me, has really kind of benefited patients. And I think the mechanism, again, remains unclear, but nonetheless, it has been proven time and time again. And then also reduce the risk of recurrence and death in early stage breast cancer patients. Also, with the aromatase inhibitors causing bone loss, a lot of times kind of putting it on patients for prevention to try to reduce any risk there. So the risks. So ONJ is osteonecrosis of the jaw. It is extremely low with a once yearly infusion. So it is certainly much more frequent when patients are getting reclassed, or the other name for it is Omeda, every month. And that is certainly a different class of patients, not just breast cancer patients, but kind of all comers. So patients who have bone metastasis, a lot of times we'll do that for prevention to kind of strengthen the bones and really try to reduce fracture at the site of that disease within the bone. And so those patients are, at least in the beginning, oftentimes getting it every month. So there's a huge difference in terms of the dosing. And then body aches. So just had it with the patient over the weekend, unfortunately, but patients can get body aches and chills and kind of feel like they have almost flu-like symptoms for 24, 48 hours. Happens about 30, at max, I would say 40%, but a lot of the data is closer to 30% of patients. Tends to be more with just the first infusion. So, trying to talk patients into getting a second infusion, I always bring it up before it comes up that usually with a second infusion, it's much less likely. And then AFF stands for atypical femur fracture. It's also something extremely rare. Both the ONJ and the AFF are reported in the literature. So if you look them up, you're definitely going to find them, but they tend to be more in what we call kind of like case series. So, where somebody in medicine thought it was more of like an interesting case. And so they would write about it and talk about it. And that's something we do with things that are really more rare. So it is definitely on the label. It's definitely something to kind of take into consideration. We'd like to get dental clearance, but there is some real benefit there. And all these things that we're kind of doing, we're just trying to bring that arrow more and more into the direction of improved survival. And so this is just kind of one of those additional things. So not quite anti-estrogen, but something that we do talk a lot about patients. And I thought there may be questions about it, so I'll kind of add it to the talk.
Thank you so much, Dr. Moore. And are there questions that people would like to ask? I'm going to stop the recording just so people can ask questions. And if you think, oh, I don't want to be recorded asking a question, then you won't have to be. So I'm going to say thank you on behalf of Carolina Breast Friends for a great presentation.